Welcome to Ariadne Labs. I'm Atul Gawande. I'm the director. Healthcare is a labyrinth of complexity, and we're producing some simple threads that show our way out of the complexity to better care, more caring, higher quality, hopefully lower cost as well. We are a joint center for health system innovation. We're trying to create scalable discoveries that can improve care for people by the millions. We're really focused on solutions for better care at the most critical moments in people's lives everywhere. We have 3 programs. The first program was in surgery. Surgery is hundreds of different kinds of operations that can go wrong in thousands of different ways.
I'm Bill Berry. I spent most of my life as a cardiac surgeon, and I'm the chief medical officer here. The Safe Surgery program goes back to 2006 when we were first approached by the WHO and then led to the creation of the WHO Surgical Safety Checklist.
We found that a simple checklist that teams could use during operations, just like a pilot's checklist, that when carefully constructed and actually used, it could cut deaths about half.
She's here for a total thyroidectomy. She's in the correct position, which is supine. We have the correct equipment.
The Safe Surgical Checklist is filled with simplicity. That's really what the whole thing is all about. Very simple things like introducing yourself.
I'm the resident, Patricia Chewy.
I'm the anesthesia attending, Suzanne Klein.
Is the patient going to need blood? Is the blood ready? All the way up to making sure that we didn't leave anything in the patient, like a sponge or an instrument or something like that.
4, 6, 8, 10.
We know that over 4,000 hospitals have downloaded the materials from the World Health Organization's site. South Carolina is a project where we are committed to widespread implementation of the checklist in an entire state. We've actually made a whole nother set of checklists called the Operating Room Crisis Checklists that are focused on emergency care. We have a big national project to spread to ambulatory surgery the use of a modified version of the surgical safety checklist. For us to move the checklist internationally really effectively into low resource settings, we really need to understand better what the barriers are. And Rwanda is a place where we're trying to understand that deeply. There's places where it sticks and where it doesn't. We are devoted to understanding why that is and then trying to fix that problem.
We were a group of 5 people that started out with the World Health Organization in this project around making surgical care better. But it became more than 40 researchers and scientists from Brigham and Women's Hospital, the Harvard School of Public Health, and other institutions with partners in 70 health systems in 7 countries doing multiple projects.
What do you think accounted for the difference, the changeover?
I'm Stephen Ringer, and I'm a neonatologist. At the time of birth, across the world, it is one of the times of highest risk for women, both in terms of morbidity, but also in terms of mortality. Even more striking is probably 3 to 4 million children die each year across the globe. The development of the Safe Childbirth Checklist was done really in conjunction with the World Health Organization. A successful pilot trial led to a large clinical trial in northern India. Uttar Pradesh, which is poor and largely rural, it has about 200 million population. If you can have success in Uttar Pradesh, you can have success anywhere.
I'm very interested in understanding how you have found the checklist in implementation.
The main trial is a randomized trial in 120 facilities across the state.
So when you use these, are you mostly using them by following them on the wall, or do they use the written checklist?
Our team spends a lot of time working with the healthcare providers there and providing support for them as they learn to use and adopt the checklist. One of the very important points about the checklist is that it is fairly straightforward. Simple supplies like soap and water, gloves, thermometers, blood pressure cuffs, and a few medications. What to us seems trivial is often a major issue in the developing world. We have partnered with an organization in India. What we have is an expanding staff getting information on how well we're implementing the checklist.
So you're happy with it?
Yes, I'm very much happy.
Yeah, that's good.
The short-term goal over the next couple of years is demonstrate the efficacy in reducing maternal and neonatal mortality and morbidity. Ultimately, our goal would be to see it implemented across India, across countries in Africa, where the need is greatest.
We have emerged from startup phase to chaotic phase. Ariadne Labs is going to be a place with about 100 to 150 people, some real experts in software and data sciences, in the science of quality improvement and implementation, and a team that can run large-scale experiments and trials. Being able to achieve great care and make that possible for society requires us to be able to also deliver on solutions that are going to improve the costs of care, improve the value of care.
Hey Tim, good to see you. How are things going?
They're okay. They're not great. This was kind of a rough week, but
I'm Susan Block.
I'm really focused.
I've been a palliative care clinician for 30 years. Patients often don't get the kind of care that they truly want at the end of their lives. Many people are dying in intensive care units. Families are left on their own trying to negotiate very difficult healthcare systems, and the care is extraordinarily expensive. 25% of all Medicare costs take place for patients in the last year of life. I'd like to think with you a little bit about the big picture of where we are with your illness and what might be coming down the road, and to see if we can begin thinking together. The program that we have developed is a serious illness communication guide. We're still in the midst of our testing of this intervention with cancer patients at Dana-Farber Cancer Institute. We've enrolled nearly 500 patients, family members, and clinicians in the study. But I'm also afraid that we're getting into some territory where we need to start planning for the possibility that things may not go as well as we hope.
Okay.
When we're training clinicians to have this conversation, we do a demonstration with an actor who's trained to act like a patient. I think that having these kinds of conversations will help me be a better doctor for you and know how to kind of focus your treatment and make sure. Doctors need a conversation guide to deal with patients with very advanced illness because it's incredibly hard to do. How much are you willing to go through and stay alive, in a sense, for the chance of having some more time?
I want to see as much of my kids as I can.
Our primary focus is on doing an intervention that is going to improve the quality of care that patients and families receive. We think in doing that, it will also save our healthcare system a great deal of money. But I think it's very important to emphasize that the goal here is quality.
We have about 40 people who work here, but we have 100 more researchers and scientists who are incredible people who are coming together on a regular basis, week in, week out, debating and solving many of these kinds of problems and trying new approaches that others haven't even contemplated yet. I really do think Boston can become the Silicon Valley of health system innovation. That we're a place that has incredible healthcare people and institutions, combined with information technology and engineering capability in our schools and in the organizations and companies in the area, to a state and a public citizenry that have been committed, 7 years ahead of Obamacare, to ensuring universal coverage for our population. That kind of place is a fantastic opportunity to build a wider community of people who are all looking at the same elephant, the same labyrinth, and wanting to unknot its complexity.